I'm Dr. Alexis LaPietra. I'm the Medical Director of Emergency Medicine Pain Management at St. Joseph's Regional Medical Center in Paterson, New Jersey, and an emergency physician. So the novel treatments for the management of pain can be used in patients who fail standard of care, but they do play an important role as a first-line treatment as well. For example, with kidney stone pain or renal colic, there are a group of patients who would prefer not to receive opiates or intravenous anti-inflammatories for either allergies or for other concerning conditions. The alternatives, if not using anti-inflammatory opiates, are very limited. So intravenous lidocaine is a modality that can be used as an alternative to intravenous opiates or intravenous anti-inflammatories. It can be used if patients fail standard of care, or it can be used as a first-line treatment. There are lots of studies looking at intravenous lidocaine for post-operative pain, and it is an efficacious analgesic. Pain scores are significantly reduced with its use, and a few studies looking at renal colic show that it's actually more effective than opiates for the treatment of renal colic pain. So it's a nice alternative when other modalities have not worked, but it's also a fantastic first-line medication for people who would rather not have standard of care. Intravenous lidocaine is not a typical first-line medication for renal colic in the emergency department. The research is small, but the research is very compelling. I think in order for it to become a first-line standard of care, emergency physicians will need more research and we need to continue to validate its use. But the use in post-operative settings for abdominal surgery as well as cardiothoracic surgery have revealed that compared to placebo, it does reduce pain at rest, reduce pain with movement, allow for quicker return of bowel function, and even decrease length of stay in the hospital. Other alternative medications or modalities that we're using in the emergency department include topical medications as well as trigger point injection, both of which can be used for acute musculoskeletal injury or pain, as well as chronic musculoskeletal complaints. Patients who come in with back sprain or strain, they may have tried anti-inflammatory or even opiates at home and feel that they're not getting adequate relief. In the emergency department, we want to utilize a multimodal pain approach as much as possible in an effort to allow medications to synergistically work and not rely solely on one type of medication to achieve adequate analgesia. So the goal is to remember that anti-inflammatories play a role in musculoskeletal pain. Combining acetaminophen to an anti-inflammatory has been shown to improve pain score compared to them being used alone. And also, we often forget to utilize topical medications. It's a great way to apply targeted or focal treatment to an area of pain with very minimal side effect. Topical medication is meant to work locally at the site of inflammation and with very little systemic absorption. So patients who might not be able to take an oral anti-inflammatory can benefit from a topical anti-inflammatory. So remembering that there are other ways to administer some of these medications is important in the emergency room, and I think the skin is often an organ we don't remember can be used as a mode of administration. Additionally, trigger point injection is an intervention performed by physical medicine and rehab physicians or pain management physicians, but it's easily applicable in the ER and it has a lot of applications. For example, chronic low back pain or acute neck spasm. The trigger point injection can help break up that spasm in a way that other medications cannot. By putting the small needle in a very irritable area of muscle spasm will allow that muscle to relax, and you can achieve significant analgesia and relief immediately, whereas some systemic medication may have side effects, may sedate patients, and may not be as efficacious up front. In the emergency department, there are not a lot of clinicians that are trained in trigger point intervention. It's a classically pain management or physical medicine owned procedure. But through my pain management fellowship and working with anesthesia, physical medicine, rehab, neurology, I appreciated that the emergency room, we do a lot of complicated procedures, a lot of life-saving procedures, and the trigger point injection is not overly complicated intervention. It's something that can be easily done. We have all the equipment necessary. So one of my goals is to spread knowledge and to help elevate our understanding of pain management as a whole in emergency medicine and help physicians gain the necessary knowledge to perform some of these relatively simple procedures that can be so helpful in our setting.